Hello again. This is part two of our studies of cardiovascular system, and the emphasis on this part will be on the heart itself and its most important anatomical features. So again, let's not make too much of a long announcement and introductory part. Let's go straight to the point, and let me again share the screen with you, whereas we're to practically start with the same picture that has been used at the end of first section. So we're going to just expand the image and to confirm. Heart is the principal component of the cardiovascular system, and we know that in an average person, it is always compared to clenched fist of that person. So it's not excessively large. Sometimes people say like surprisingly small compared to what they expected. Where is heart located? On the upper part of the screen, we can see transverse plane section through the upper part of the chest, the thorax, and we're seeing heart practically given the central position between right and left-sided lung. That central space between left and right lung is known as the mediastinum. And of course, it's not populated exclusively by heart and its pericardial sac. Within the mediastinum, we're going to have a number of different structures that are simply passing through that space, including esophagus, which sits, as you can see, pretty much straight in front of the spinal column. Slightly to the left side, it is aorta. On this diagram, we can also see here part of the pulmonary trunk arising from the right ventricle, splitting into left and right-sided pulmonary arteries, obviously taking deoxygenated blood into the lungs for the purpose of oxygenation. The lower diagram might be a little bit easier to comprehend because sometimes I know that students without so much experience in anatomy do have some difficulties observing structures that are illustrated on a different cross-sectional plane other than one that we're used to see things kind of in front of us. So for that reason, frontal plane section through the chest wall, as illustrated in the lower part of the screen, might be a little bit easier to grasp and to point again. This is the mediastinal space. The term mediastinum, loosely translated from Latin to English, means the center part or centerpiece or center space of the thorax. Heart certainly is its largest inhabitant. And together with the heart, of course, we cannot avoid seeing those largest blood vessels that are either arising from the surface of the heart, such as aorta or pulmonary trunk, and also to see some other large veins that are passing through the mediastinum in order to reach the heart, such as superior vena cava being illustrated here. Inferior vena cava will arrive from the abdominal space, will pierce the diaphragm, and also in order to reach and empty its content into right atrium of the heart. The cutoff point, the dotted line, identifies borders of the heart, but at this point we can use it with more practical value, simply saying that the black dotted line identifies the cut area where we had to cut open the membranes that are surrounding the heart. These membranes that are collectively known as the pericardial sac is going to be the first topic that we're to discuss, because the heart itself, being pretty much quite active with its contractions and relaxation happening between 60 to 80 times each minute of our life, obviously there will be lots of friction between heart in its contraction and relaxation against the wall of its direct neighbors, in this case lungs, left and right, and also other structures that are technically either behind or in front of the heart, such as the wall of the thoracic cage. So the pericardial sac is something that ensures that the heart is given its steady position. Pericardial sac is also attached to the upper surface of the diaphragm and partly attached to the anterior wall of the chest, ensuring that as the diaphragm keeps elevating, depressing itself, together with it, heart and its pericardial sac is also elevated and depressed in sync with the movement of diaphragm as the principal muscle of respiration that we should know from physiology and anatomy of the respiratory system. So let's go on to the next slide, which will give us a little bit more detailed approach to understand what is actually the pericardium. If you take a closer look, you will find out that what is labeled as the pericardium has certain thickness added to it. And when we go further down, we realize that there are multiple named layers of pericardial sac. One of them being fibrous pericardium, that is the outermost layer. So its name, fibrous, immediately implies to something that has quite a large number of fibers in its walls. And fibers indirectly give us idea of some kind of physical resilience, strength, specifically against the overstretch. So the fibrous pericardium practically limits the space that heart is given during its cardiac cycle, determining that we cannot fit or force fit 3 liters of blood to fill the heart's chambers all at once. Heart has its limits, its capacity, and the fibrous sac is the one which actually reinforces it, preventing heart from over distending its walls, and perhaps it would lead to earlier than needed injury and problems coming from overstretched muscle of the heart. Immediately next to it is parietal layer of what we call the serous pericardium. So again, the emphasis is on the word serous. What does it mean? It is a much thinner membrane, physically fully adherent to the fibrous pericardium, but due to its gentle secretion that is simply oozed from this layer of serous pericardium, it produces very minute amount of fluid, pericardial fluid, which actually lubricates the pericardial sac. And that lubrication actually is what completely eliminates any signs of friction between the heart and its imminent surroundings, regardless whether heart is in a full systole or full diastole. Friction should not be allowed. And then this layer of parietal pericardium, and parietum, I'm sure that you remember from past section, means the wall. So parietal pericardium, after it has lined the fibrous pericardial sac, approaches the walls of the large blood vessels, folds upon itself 180 degrees turn, and then it continues being firmly adherent to the outer surface of the heart. This time it remains serous pericardium, but we call it visceral layer. Viscerum, as you know, means organ. So between parietal and the visceral layer of serous pericardium, there is even a tiny space. The space is known as the pericardial cavity. It should have no content other than few droplets of pericardial fluid. So when we have two serous surfaces, one parietal, one visceral, which are both lubricated, regardless of how much movement happens between them, friction is eliminated. Think about it, if you want, as when you go to the bathroom to wash your hands, and when you put enough water to wet your hands and then spread out, let's say, liquid soap. In a couple of quick moves between your hands, the soap is spread in a form of very thin film all over your hands, practically eliminating any further friction. You can wash your hands properly, rinse them, dry them out later on. We do not have the same type of principle, washing and drying, but we rather prefer to have pericardial sac being wet and that kind of wetness between parietal and visceral layer of pericardium is essential for mechanical support of the heart's action. Please note that the visceral layer of serous pericardium also gets another name, which is perfectly legit to use. We can just use that word pericardium, becoming now epicardium. Word epicardium, prefix epi, means on the top of a structure. So clearly, epicardial layer or visceral layer of serous pericardium is the one which covers the outer surface of the heart, and it is not just a membrane which is wrapping up the heart. Instead, it's a membrane which is completely and fully integrated into heart's surface. Remaining part of the diagram, which you would need to see and grasp right away, obviously shows what is the thickest part of it. It is the wall of the heart, which is myocardium, made of myocardial heart muscles, and of course the inner aspect, illustrated in some kind of pink purplish shade, practically identifying the innermost layer which lines up the chambers of the heart. It's called endocardium. Endo, inside, cardiac or cardium, heart. So innermost layer is endocardium, which makes sense as endocardium is actually just a continuation of endothelium that was lining blood vessels, enabling, again, same type of smooth surface, which doesn't interact with the blood in any negative form. Blood just simply slides and glides against the endocardium, practically not being traumatized, not triggering spontaneously any unwanted events, such as it would be coagulation of blood and creating of thrombi, which eventually, if they detach, would be freely floating through the system, turning thromb into an embolus, with possibly even some kind of consequences that could be even lethal. So let's recap here. Pericardial sac ensures that the heart is given its space and that the heart's not given too much of the freedom to overexpand. Outermost layer is the fibrous pericardium. Obviously, that is the firmest part of the pericardial sac, attached to the diaphragm, attached to the anterior chest wall, but it is lined with a membrane that is called the serous pericardium. This is parietal layer. Parietal layer reaches surface of major blood vessels, where it makes U-turn, 180 degrees turn, and then as a single continuous layer starts covering the very surface of the heart, practically turning itself into visceral layer of serous pericardium or the epicardium. Other two layers that we will be seeing for the rest of this presentation are the myocardium, that is contractile part of the heart, its real muscular force, and what lines the chambers is endocardium, which practically is continuation of endothelium of blood vessels that we mentioned in the first part of this presentation. If you need something to understand it better, how the pericardial cavity is formed and what is truly a difference between parietal and visceral layer of serous pericardium, this simplified illustration could be really good and very illustrative. Think about pericardial cavity first as one soft, inflated, elastic rubber balloon. Because of its soft inflation, if you push the heart into it, obviously the wall of this bubble will start changing and conforming to pretty much adhere as close as possible to the surface of the heart, which is pushing that. If this continues, as you can see on the right side of the screen, obviously the softness of the balloon was not hard enough to prevent heart from fully being embedded into it. Balloon is still intact. It did not burst. It has its walls that are one oriented outward. That becomes parietal layer, and this is attached directly to fibrous pericardium, while the rest of the wall is attached directly to the surface of the heart, turning itself into a visceral layer or epicardium. In between them is the trapped space, the pericardial cavity, which we know would contain only a couple of droplets of pericardial fluid, ensuring that it is properly lubricated and that no friction is encountered as a consequence of heart cycle. Back to the diagram, which has been used before, just to confirm what we already know. So a little bit of a step backwards, so to say, to revisit. Heart being in the center of the system, being made of two atria, two ventricles, left and right side. The right side of the heart handles deoxygenated blood, which is collected from the body. The left side of the heart, atrium and ventricle, they're handling oxygenated blood coming from lungs, and then force of contraction of the left ventricle distributes oxygenated blood into a system of arteries, arterioles, into body capillaries, where exchange of gases, nutrients, waste products is taking place, and then blood flows smoothly through venous end of capillary bed into venules, then into larger and then largest systemic veins, superior inferior vena cava, bringing deoxygenated blood back into the right atrium. Right atrium, after its short contraction, fills up maximally right ventricle, which is then due contraction on its own, pushing blood out of right ventricle into pulmonary trunk and then left and right-sided pulmonary arteries that bring deoxygenated blood into the lungs, into a system of pulmonary capillaries, where oxygenation process takes place. Blood gets rid of carbon dioxide, and in turn, it absorbs oxygen from alveoli and across the alveolar wall. Basically, we know this is the respiratory membrane. Once the blood has been oxygenated, it is collected and moved away from the lungs by a system of 2+2 pulmonary veins, which bring oxygen-rich blood back into left atrium, and we would be at the beginning of the next cardiac cycle. So no need for us to elaborate anything much further. It is just a recap of what we should know by now, and we move on to try to understand a little bit more about what is heart really made of. Forget the pericardium for a moment, forget the endocardium as well. Just focus now in your thinking about what is the myocardium. Obviously, myocardium is a layer which is most significant as it is composed of cardiac muscle fibers. They communicate between themselves. They have a special electric connections that allow electrical signal to be spread from cell to cell and allow very coordinated contraction of heart's musculature. Because we cannot compare heart with any other skeletal muscle. We know that muscle of our locomotor system would require at least to have two attachment points in the skeleton. One which is attachment that we call the origin, the other one being called the insertion. And as the muscle is attached to two or more different bones of the skeleton crossing at least one joint, contraction of the muscle enables part of the body to be actively moved. Now, the heart doesn't have any skeletal components onto which it may attach, and that's why it's important to understand, and perhaps it's a little bit too early, but I have to say it now. There are some kind of fibrous rings and fibrous triangles in the center of the heart between atria and ventricles. These fibrous structures actually allow for the attachment of myocardial cells, and their arrangement is not necessarily seen as parallel running bundles of muscles as typically seen in a skeletal muscle. Rather, they swirl around and create somewhat interesting and intriguing network that we can see only if and when we remove the layer of epicardium from the heart surface. With that kind of arrangement, basically, we're understanding that contraction of the muscle is arranged to push the blood from atrium into ventricle, and then later in a ventricular systole to force the blood to emerge out of the ventricle and to be directed into either aorta or pulmonary trunk. Here is a picture which illustrates what truly anatomical specimen of the heart looks like after being extracted from cadaveric chest. We can see here heart in a shape that is not necessarily like what we have seen on handmade diagrams. We recognize that there are some parts that are called the heart's atria, that there are some parts that are to be called heart's ventricles, but now we're seeing something that is called the auricle, right auricle and left auricle. Auricle means shaped like an ear, and these are older parts of embryonic heart, which as we change and heart is allowed to reach newer, more mature form, atria appear to be some kind of redundant structures from our embryonic past. They are not fully functional, but I don't want to also discontinue them as being dysfunctional parts. They're attached and they're parts of the atria. Towards this part of the heart that we call the base, we now start observing two major blood vessels as they arise from the heart's surface. This is the pulmonary trunk, which obviously originates from the right ventricle. This is aorta, and because aorta and the pulmonary trunk look like being braided together, we cannot say that we see where exactly aorta comes from, but we know and we will confirm from our studies that aorta actually arises from the left ventricle, which is handling oxygenated blood. Further, we follow aorta. We're going to start seeing some of its branches. Obviously, brachiocephalic trunk, left common carotid, left subclavian artery are three largest ones, taking blood away from aorta into head, neck, as well as upper limbs. Further behind aorta, we now we're seeing parts of our venous system. This is superior vena cava, which collected venous blood from head, neck, and both upper limbs. And of course, it is now heading towards right atrium in order to empty its content and to send blood through the right side of the heart for another round of oxygenation. Even in this picture, you can see and right away notice the difference in structure of aorta, which is elastic artery, and compare it to somewhat looking collapsed wall of a vein. Remember the difference in thickness of typical artery versus thickness of typical vein. That is why the veins on these realistic anatomical models would always look significantly different compared to any other artery that you observe nearby. Once we do a little bit of dissection on the heart itself, basically we're removing parts of the myocardial wall in order to verify and to visually inspect what are the chambers of the heart. We know that there are two of them that are called atria, and there are two of them that are named ventricles. So here we're having a chance to see what's inside the right atrium. Part of its wall is cut away, and you can see these bundles of muscle fibers that they're arranged in an almost perfectly parallel form. They're called pectinate muscles. So this is myocardium, but with a very unique form, shape, and arrangement, good enough to be given a proper name. Here is the right-sided ventricle. The ventricle, you can say right away, looks a little different compared to what we're seeing inside the right atrium. Firstly, its wall looks structured much differently, and that arrangement of myocardium actually results in a much smaller bundle of muscle fibers being arranged in somewhat irregular form of arrangement, and they are referred to as trabeculae carnae. Trabeculum means a beam, carnum means flesh or meat, and within the right atrium, within the right ventricle, you're also seeing something else, which is interesting. This is part of the valve which regulates blood flow through right atrium into right ventricle. I apologize. Right atrium to right ventricle. This valve, when it closes, it will prevent that the blood is reversed to flow right ventricle backwards into right atrium. Something quite similar exists within the left ventricle, and these valves will be subject to our independent individual studies, and we'll describe them later on in this presentation. Valves need to also have some kind of physical force which keeps them closed during ventricular contraction, during ventricular systole. That's why within ventricles, we're going to see quite large muscles shaped like a nipple, hence the name, and we're calling them papillary muscles. Papillary muscles are attached with chordae tendineae to the free edge of valvular cusps. It is important part that we're to see within ventricles, papillary muscle, chordae tendineae, and valvular cusps, because as I mentioned it, and I'm stressing it out once again, during ventricular systole, valves must be closed to prevent retrograde movement of blood backwards into ventricle to atria direction. In order to keep the valve closed, papillary muscle is contracting, pulling on chordae tendineae, which pull in turn on the valvular cusps, preventing them to be forced open into direction of atria. We will talk about it more later on, and this is just our preliminary view to find out what do we see inside the heart's chambers. This is still the pulmonary trunk. This is aorta with its three branches, brachiocephalic trunk, left common carotid, left subclavian, and part of the aorta from which these three arise is called aortic arch. Part of the aorta, which is arising directly from the left ventricle, is called ascending aorta. Then it turns into aortic arch, and then aorta starts its descent through the thorax and abdomen. Hence, that part is called descending aorta. We still see here some large veins, such as brachiocephalic veins coming from the left and right side, getting united and forming superior vena cava, which enters the right atrium. The purpose of this picture is really only to remind you of what we have said already. Now the focus is away from pericardium, just to understand this is the myocardium and this is the lining of chambers called the endocardium. Myocardium within the atrium formed pectinate muscles due to its parallel bundle arrangements. Within the ventricles, arrangement of myocardium look much different, hence being named trabeculae carnae. And within our ventricles, we're expecting to have also papillary muscles, chordae tendineae, and then attachment of chordae tendineae onto free edge of valvular cusps or leaflets, if you want to call them a different way. Now, this is a handmade picture of what the heart looks like, and I think for anyone studying this part of anatomy, it is much, much easier to take a look and to understand what we see here. Two colors are used in order to perhaps enhance a little bit more of what's happening in a deoxygenated blood section versus red color being used for oxygenated section of the heart. There is a little problem because if this is right atrium, which receives deoxygenated blood from the superior and inferior cava vein, blood from the right atrium and the right auricle actually goes down to the right ventricle. So this part of the heart also should be colored in the same light blue color to identify handling of deoxygenated blood. So the heart pumps it out into pulmonary trunk, which splits into left and right pulmonary artery, reaching the lungs capillaries for oxygenation. Okay, here is the left auricle, and therefore slightly behind it, we cannot see from this anterior viewing experience of the heart size or absolute position of atria. It's going to be seen a little bit better when we turn the heart by 180 degrees. And now we can say, aha, this is the left atrium. This is the right atrium. Right now, we don't see much of auricles, but what we see here is 2 + 2 pulmonary veins that enter the left atrium. And here we see both superior and inferior vena cava entering the right atrium. This, of course, is still aorta, and this is the pulmonary trunk, which is dividing into left and right-sided pulmonary artery. We'll go back and we'll try to grasp some other important features and some principal terminology. A heart, which is, as I mentioned it earlier, about the size of your clenched fist, is about 2/3 on the left side of the chest cavity, and about 1/3 projects onto the right side away from the midline. It is shaped as three-sided pyramid, which has been tipped sideways. So the uppermost part of the heart actually is the base of that kind of pyramid, and opposite part, which we tipped sideways, is where the arrow is currently pointing. That is called the apex or tip of the heart, the base and the tip. And then we have three different surfaces, which are not so easy to discern which one is which. The one which you can see here the best is anterior or sternal surface of the heart, the one which is directly behind the sternum. This lower surface is called diaphragmatic surface because it really sits on the very top of the diaphragm. And when we turn the heart again by 180 degrees, we're going to see most of its left-sided surface being mostly composed of left atrium and left ventricle. So from the base, three different surfaces are to converge, and as they do so, they form the apex. Strangely enough, other than recognizing left and right atrium, which we pointed so far a couple of times, there are no other interesting anatomical features for us that we can say they're named and that we should be able to see them right away, other than three grooves. Groove in Latin is called the sulcus, and here we have the first one, which appears to be running circumferentially around the widest aspect of the heart. That groove is known as the coronary sulcus or coronary groove. Like a crown, corona means the crown, it goes 360 degrees around heart. And it is for us an excellent landmark, which gives us a chance. Whatever is further above superior relative to coronary sulcus, that is atrium, whether it's right or left. When we see the back side of the heart, we can see even better the coronary groove, clearly separating right and left atrium from respective side ventricles. Coronary sulcus contains major blood vessels, so-called the coronary blood vessels, that are feeding the myocardium. It's a little bit of a paradox. The heart's chambers are bathing in blood, but that blood cannot penetrate and feed the myocardium. We need to take it from aorta, distributed into coronary vessels that further spread over the surface of the heart with their perforating and penetrating branches. They finally enter the myocardium and provide blood supply to very active muscle. Any kind of blockade that one can experience in either major or some of the peripheral blood vessels that are feeding the myocardium basically is what leads to heart attack, myocardial infarction, where a segment of the myocardium is deprived of fresh arterial blood, and as a result of that, basically we're seeing damaged myocardial structure, which result in either minor, but unfortunately sometimes also the major size heart attack, which, as we know, could be fatal. Anterior side of the heart shows us anterior interventricular sulcus. Obviously, anterior, we know what it means, interventricular, between ventricles, while on the posterior side of the heart, we're seeing the posterior interventricular groove or sulcus. They're also excellent landmarks because these anterior and posterior interventricular sulci are helping us visually say this is the right-sided ventricle, then comes the sulcus, and on the opposite side of it is musculature of the left ventricle. Same could be said for the posterior interventricular sulcus, also acting as the borderline between right and left-sided ventricle. And before we move on to the next slide, I also want to make sure that you understand that there is, even in a healthiest individual, a little bit of adipose tissue that may be covering part of the heart surface. Nothing to worry about. This is just one extra space where a little bit of additional adipose tissue could be deposited. It does not necessarily affect the heart and its health. The heart and the health of it is determined through properly functioning and properly supplying coronary blood vessels and their branches, properly functioning valves, properly functioning and properly contracting myocardial layer. However, this amount of adipose tissue is going to be just seen as something that is normal anatomical finding. As we would progress with our studies a little bit further, we're going to stop here again on this diagram because the next step that we have to make is to start looking into individual four chambers of the heart one by one. We're to start with the right atrium, move on to right ventricle, and then do the same thing with the left atrium, left ventricle, and then to also discuss valves. There would be a total of four of them, fibrous skeleton of the heart, and to kind of come closer to completion of studies of what anatomy of the heart is. So we're going to stop here and wait for part 3 to be recorded and posted. And I hope, again, this was not bad part, not bad recording, and that it was fairly instructional and it wasn't difficult for you to follow it. Thanks for watching it. See you soon in part 3.